Hello, I'm Jan Leifman.
And I am Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Ruben Mesa. Dr. Mesa is the executive director of the Maze Cancer Center at the UT Health San Antonio MD Anderson.
In today's presentation, Dr. Mesa discusses the major goals in the ever-evolving therapy of myeloproliferative neoplasms.
Did you know that Dr. Mesa contributed to the US FDA's approval of ruxolitinib for polycythemia vera and myelofibrosis and fedratinib for myelofibrosis? He also led the development of the first US NCCN's panel guidelines for the diagnosis and treatment of myelofibrosis, polycythemia vera, and essential thrombocythemia.
He is an inspiration as a pioneer in the field of oncology.
So let's tune in and learn from this global leader.
Now, excitingly, there are new non-JAK inhibitor mechanisms of action. The last patient I saw today, and indeed I saw and raced home to give this talk for you all, was to put a patient on a non-JAK inhibitor mechanism of action clinical trial. And these are exciting to see these rolling out. Indeed, there is an unprecedented number of alternative targets being looked at, usually with or without JAK inhibition as kind of a cornerstone. Cell cycle checkpoint, anti-fibrosing agents, other signaling tyrosine kinase inhibitors, agents looking at the apoptotic pathway as they've been successful in MDS and AML, other immunomodulatory drugs, or a range of things that are epigenetic modifiers. So let me start with the first. This is in the MANIFEST study. This is with the BET inhibitor pelabresib. This has created quite a bit of excitement. And these slides were just presented again a few days ago by my colleague Claire Harrison in Vienna, for those that had the opportunity to attend. Again, it has been felt since the beginning of the rollout of this agent that the combination of both BET inhibition and JAK inhibition may be beneficial, and that there's a synergistic effect in the combination of these two agents. The MANIFEST study was a study designed when the agent was with Constellation. The agent is now with the company Morphosis, but with multiple arms that can to evaluate a variety of scenarios, either alone as monotherapy, in combination is either frontline or as an add-on or as a second line. So multiple different approaches, of which the one that I think has gotten the most excitement and really captured the imagination is the thought of two drugs from the get-go in JAK inhibitor naive patients to optimize response. And these are the data that Professor Harrison shared with us in Vienna, which showed very significant responses in terms of splenomegaly and in terms of symptoms. Indeed, you see here in this waterfall plot that the vast majority of patients had significant reduction in splenomegaly, and that SVR35 at any time was 80% of the patients, with 69% maintaining it at the time of data cutoff. And likewise, the median total symptom score change was an improvement of 60%. So these are really some of the very best data we've seen to date for a combination approach for therapy for myelofibrosis. Here you saw, again, individuals that had a suboptimal response to ruxolitinib. When you add in the other agent, again, achieving good response in arm 2. You see here in arm 3, the combination leading to durable improvement in that spleen volume, both in the frontline setting on the left and in the add-on strategy on the right. These data do tend to suggest that there may be advantages to using the combination upfront versus waiting for an add-on approach. Side effects, again, there's a theme here, cytopenias and GI. So these, again and again, do seem to be a recurring theme in terms of side effect with new medicines in MPNs and need for management. Again, as one looks here, arm 2, very similar in terms of the spectrum of toxicities. Interestingly, there were a series of correlative studies that were also presented that showed the potential of some improvement in fibrosis for these individuals, and they are currently using new digital pathology mechanisms to further interrogate these data. And there was also some correlation of improvements with some other digital pathology measurements as related to fibrosis, as well as other histologic changes that could be assessed through digital pathology. All of this has led to the MANIFEST-2 study, which is actively accruing as we speak. Certainly would strongly consider anyone that's watching this, if you have a patient that is a candidate for JAK inhibition, newly diagnosed with myelofibrosis, consider the MANIFEST study before they begin on JAK inhibition. So this is for JAK inhibitor naive patients. Rux versus Rux plus pelabresib. The second agent, and there's many, but I'm just highlighting a couple, is navitoclax. This is a cousin of venetoclax. This works against BCL-XL. Indeed, it's been known for a while that there can be apoptotic resistance in myelofibrosis. Indeed, a million years ago, this was the subject of my NCIK award when I was in the lab of Dr. Scott Kaufman. And indeed, it's gratifying to see this kind of come full circle with a therapy targeting BCL-XL. Francesco Passamonte presented some updated data. Like the MANIFEST study, there were multiple cohorts, and they presented at EHA the cohort of individuals that were JAK inhibitor naive. And here very specifically, both JAK and BET inhibitor treatment naive to not confuse matters. And they were started on navitoclax plus ruxolitinib with, again, improvements in splenomegaly and symptoms. In terms of toxicity, and there were a range of low-grade toxicities, but overall the investigators felt the drug was well tolerated. Potential of cytopenias and GI side effects, again, should not be a surprise. Thrombocytopenia perhaps being a bit more represented. Here you see reduction in splenic volume, and again with 63% of individuals achieving a spleen volume reduction under 35%. On the right, you see the durability of those response. And then you see here about a 41% improvement in symptoms. And again, this is in a single-arm phase 2 study. So the numbers are small. And it's also very difficult, I'd say, to compare these data versus the data I showed you again from the single-arm phase 2 of MANIFEST. I do think the phase 3 study are going to be looked at very carefully. They're not going to be randomized between each other, but I think with those numbers and power, we may get a better sense of, how do these things look like side by side. Some improvement in fibrosis. And again, I think the evolving mechanisms with digital pathology will be helpful in sorting out these data. We're at an unprecedented time with the greatest number of phase 3 trials ongoing in myelofibrosis, truly ever, in a recognition of advances in the disease. So one, there are drugs where we're looking at truly for individuals that have failed JAK inhibition. There's currently a telomerase inhibitor trial with imetelstat that is ongoing as a second-line therapy with survival as the primary endpoint. There are the add-on studies. Luspatercept to help to improve anemia, that's ongoing and accruing, would Recommend you consider that for that TGF-beta ligand trap and help to improve anemia along with ruxolitinib. Navitoclax, which I mentioned, parsaclisib, PI3 kinase inhibitor from Incyte that's active and may help to add to the benefit of JAK inhibition, and the MDM2 inhibitor from Kartos. There are the combination studies in JAK inhibitor naive patients. Pelabresib, which I mentioned, Manifest-2, Navitoclax combination, and the PI3 kinase inhibitor. So again, a robust pipeline of studies. Again, if you have patients with myelofibrosis, certainly be considering, if things aren't going ideally, should we consider a clinical trial? And if they're JAK inhibitor naive, consider one of these, because they're going to get ruxolitinib as the control arm or in combination in these, and we hope that these are incrementally better. So how do we help put all this together before we pivot to some time for some Q&A? Well, first, in patients where transplant is not selected, I think in low-risk individuals, we're going to be thinking about, one, if they're not symptomatic, observation or pegylated interferon. If they are symptomatic, ruxolitinib or a clinical trial. Again, with all those JAK inhibitors, only ruxolitinib has really been used in lower risk disease. In individuals that have a platelet count under 75,000 in intermediate to high risk, pacritinib. If they're anemic, momelotinib, or perhaps a combination, ruxolitinib plus luspatercept, ruxolitinib plus pelabresib. Or if they have standard myelofibrosis, normal counts, probably still ruxolitinib or fedratinib. There will be a subset at a minimum that I think we will identify. Benefit from combination therapy upfront, rux and pelabresib or navitoclax or parsaclisib or another. I do think the data from the phase 3 will be important to identify. Is that everyone? Is that a subset? Patients with a platelet count less than 50,000, pacritinib. Second line, if the spleen is a major issue and the counts are okay, fedratinib. Anemic, momelotinib, or again a combo. An increased risk, again, I think it'll go back to those combination approaches. Accelerated or blast phase, this is a tough group of patients. Some sort of enhanced induction. 7 and 3 doesn't really cut it in these patients, not very well. So if there's a target, use a target, consider a trial. No transplant, Rux plus a targeted therapy, if there's a target, is both the ongoing efforts in clinical trials and hopefully beneficial. If you fail frontline therapy, I don't think there's really a lot of rationale for second-line therapy in this group of individuals off study. I think a trial or support the survival in secondary AML from MF is very poor. And if there's not really a transplant in sight, I would be very judicious about therapy. How do we bring this to really precise and personalized cancer care? Well, I think we've learned a lot more about the clone, but there's a lot more to having a disease like this than just the clone. It's got to live in a person who has all these other issues, their risks, their comorbidities, their other medications. How do we weave together all of the factors to try to come up with the best treatment plan for really what is a chronic disease that we're trying to make a great impact upon and work in a shared decision-making model with our patients? With that, I very much would like to thank many individuals, clearly the tremendous MPN community. One of the things that's been very rewarding about being in this community, tremendous patient engagement, wonderful investigators, people very generous of their time and eager to collaborate. It truly is a wonderful space to be involved in, and some wonderful organizations that really have helped to make tremendous support. The MPN Research Foundation, the Leukemia Lymphoma Society, MPN Advocacy Education International, the MPN Education Foundation, and many others. And certainly many wonderful friends and collaborators. Working in teams is one of the exciting things we all get to enjoy as being in academic medicine. And with that, again, my thanks for the invitation.